Good afternoon. Welcome back to Community Conversations with the UI Cancer Center. Community Conversations is a weekly show hosted by the UI Cancer Center where we highlight UI health and community partners, cancer information, and our different cancer-focused programs and interventions. Our aim, built around the UI Cancer Center's bench to community model, is to disseminate educational cancer and other health information to the community. Our guest today is Nicole Fisher, Clinical Research Coordinator for the UI Cancer Center and Colorectal Cancer Navigator. Today, Nicole is joining us to highlight the Cancer Center's Colorectal Cancer Navigation Program that takes place at the Mile Square Health Centers. Thank you for joining us, Nicole.
Yeah, thanks for having me.
So, Nicole, would you mind giving us a little bit of an introduction into your role at the Cancer Center and your tenure there?
Yeah, definitely. So, I've actually been with the Cancer Center since June of this year, and my role is twofold. In my role as Clinical Research Coordinator, I help keep the target of our grants in focus.
Okay.
My role with the clinical care coordination is more within the clinics.
Mm-hmm.
It's where I navigate patients to, right now, just colorectal cancer screenings,
Okay.
making sure that they're compliant, answering any questions that they might have, and making sure that they're fully equipped with all the education so they can make an informed decision with their provider about what screening works best for them.
Great.
Yeah.
And just as a background, the Cancer Center has a group of cancer and health navigators that are stationed sort of around the different Mile Square health clinics.
That's right.
Yeah.
And I'm actually stationed in Cicero right
Okay.
now, but I've been in Maine, and I'm hoping to get into the back of the yards, South Shore. So
Great. And
yeah.
most of our programs right now focus on our four main cancer areas: colorectal cancer, prostate cancer, lung cancer, and breast cancer. But of course, Nicole focuses on colorectal cancer. So going into that, can you give us an overview of colorectal cancer?
Yeah. So colorectal cancer is a cancer that begins in the colon and the rectum. Like all cancers, it starts with cell growth. It's just kind of out of control. It's called proliferation. And it starts along the lining of the cell wall. If you want to pull up the picture there, Chris.
Yep.
So sometimes you'll get a little polyp there, and that they're usually not cancerous, but what screening is looking for usually is for precancerous polyps. But once they're inside there, they're going to take out any polyps that they see.
Got it. So just sort of overall, colorectal cancer is a cancer that grows along the
the
walls.
colon and the rectum. Now, the
Okay.
colon and the rectum are a part of the large intestine.
Okay.
The colon is about 5 feet long,
Okay.
and the rectum is 6 inches. So,
Okay.
if you just take the tip and measure here. So, yeah, that's what it's looking at, and that's what it targets.
Okay.
Now, I mean, like most cancers or any cancer, sometimes it can spread outside of that region,
Right.
but it's defined as colon or rectal cancer if it begins there.
Okay. Can you tell us some risk factors to colorectal cancer? Different
Definitely.
things that might affect getting that cancer, or any certain factors related to it.
Yeah, there are a few things. Some things are out of our control. So
Okay.
things like age or family history, even ethnicity. Those are things that we're just born with, and we have to learn how to navigate that as well as we can.
Okay.
The older you get, the more susceptible you become to colorectal cancer. And then also family history puts you in an increased risk. So with that, usually you'll want to get a colonoscopy immediately. You won't want to have to get checked up every year. You want to get a full check-in screening.
And just to go into that a little more, we talked
Yeah.
about family history a couple episodes ago about family history and cancer.
Oh, yeah.
But maybe we could elaborate a little more to what we talked about before. It's usually a close family member, a parent, a grandparent,
Right.
sibling. Is there any for colorectal cancer? I know for breast cancer, because it predominantly affects women,
Yeah.
you want to look at the women in your family
That's right.
to see if there's any history. For colorectal cancer, so do you want to look at everyone across your family? Is it sort of any family history of cancer?
Yeah, so for colorectal cancer, this is something that affects both men and women
Okay.
alike. You'll want to look at first degree family members. So that's someone you can draw a direct, like, familial line to. So, like, your siblings, your children, and your parents. Not really considering your grandparents, but if you have more than one grandparent, then that's something to also take into consideration. So yeah, that's what I mean about familial.
Yeah.
And also sometimes that goes beyond just someone who's been diagnosed. Sometimes that becomes a genetic marker, and it can be something that's passed on from a great uncle or something.
Right.
Yeah.
Okay, great. So yeah, just family history for most of the cancers we're looking at are very important. We talked about it a couple episodes ago,
Okay.
and that's all on YouTube if you're
Yeah.
interested. But are there any other factors? I mean, you had
Yes.
mentioned ethnicity as
Yeah.
a factor for this cancer. Does it affect specific ethnicities or
Um,
more so than others?
Yeah, it does. For African Americans, the incident rate is the highest, and also the mortality rate is the highest. Interesting also is Ashkenazi Jews.
Yeah.
They're more predisposed, like genetically predisposed to colorectal cancer.
Okay.
But for African Americans, we're not quite sure what the reason is for the incident rate and the mortality rate,
Right.
but we know it's there.
Right. So African Americans overall, both men and women,
Both men and women.
have higher rates of colorectal cancer and are dying at higher rates of colorectal cancer.
That's right. Yeah. And some other risk factors are, just things that we can change.
Right.
So obesity is an issue with a lot of cancers. Diabetes is kind of like a pre-existing condition risk factor, as well as another pre-existing condition risk factor would be like Crohn's disease or colitis, any irritable bowel disease. Usually you want to keep a closer eye and get more screenings.
Right.
Also diet.
Right.
If you have a high diet in red meat or fatty foods, like the way you cook your meat, if you grill it, that releases that it kind of changes the chemical composition of the meat and creates like free radicals, which are cancerous or cancer causing agents. So baking your meat is probably a better way to go if you're going to have red meat, which isn't as tasty but safe.
And yeah, we did last week talk to a couple members of the DBSR, the Diet Behavior Shared Resource, and they did talk about, for most cancers, just keeping your weight at a manageable level, and also, having a healthier diet, including, better proteins and probably less proteins overall in your diet is important. So it sounds like that also plays into colorectal cancer.
It really does. And I mean, it's good in general for your overall health. So, I mean, it's something you should just incorporate. Also, just having, a lot of physical activity, because even if you aren't overweight, but you're not being physically active, like that's an issue also.
Right. So, okay, just to
Yeah.
go back over it. So, the older you are,
Yes.
colorectal cancer, is a higher risk. And again, risk factor is not you're definitely going to get the disease or you definitely won't get the disease. It's just sort of a way to calculate, in a way, your risk of getting it. So sort of your chance of getting the disease. And so the more elements you have of these, age, based on your ethnic group, your lifestyle, including diet,
Right.
and how active you are all things that play directly into your chance of getting colorectal cancer specifically, but other cancers as well.
Sure.
So going on to, so we have a few programs at the Cancer Center that focus on colorectal cancer and navigation to colorectal cancer screening. Can you give us a description of sort of the different types of colorectal cancer screening, and if you go to your doctor and they say you need screening for colorectal cancer because of your age, your risk, what sort of things can people expect of the different types of screening?
Yeah, so I'll give you I'm just gonna give you everything.
Yeah, be exhaustive. I mean, this is...
Yeah. So there are a few tests that are better at detecting polyps than others, and some are just better at detecting cancer than others.
Right.
A few that are good at detecting both polyps and cancer. That would be, so we have like a double contrast barium enema, and it's less common here at Miles Square, at least in my experience so far. But what that is it's a little less invasive than a colonoscopy. They use barium sulfate and air, and they push that through the colon, through the anus, and that expands the colon so that you can get a pretty clear picture of, you know, what's working, what you're working with there. And the barium sulfate is like a chalky liquid, so it coats the lining so that you can, it kind of just like markers and chalks out like a chalking outline for the physician, and then an x-ray is performed.
Okay.
So you can see, you know, if there are any masses, any tumors, things like that. If there's anything detected, then you're going to have to probably get a colonoscopy anyway. But that test is good for if it's normal. It's good for 5 years.
Okay. Good.
And some people prefer it just because you don't have to go under any like real sedation and
Got it.
yeah.
And before we go on to the other screenings, I had a quick question just for myself. Is also the difference between a polyp and the actual cancer? Because it seems like that's important for a few of the different screenings.
Yeah. That's really important. So again, not all polyps, most polyps are not going to be cancerous. But the importance of screening is that, you know, you want to get the polyp before it becomes precancerous. So if you're, you know, getting a screening and they see one and they take it out, like no harm, no foul.
Right. And it's just a growth that could happen within the colon.
It is a growth that can happen.
Removable.
It takes a polyp about 10 to 15 years to grow.
Okay. Okay.
To grow to like a sustainable, you know, a size that's worth resecting, removing.
Okay. Well, I actually didn't know that. But so what other types of screening we have? What was the first one called again? Just
double contrast barium enema.
Right. And that's one that we at the cancer center we don't usually.
I mean, it's done, but you know, I haven't really navigated any patients towards that.
Got it. And so what sort of screens do we navigate to mostly?
Right. So that would be like a colonoscopy, and your sigmoidoscopy, which are very, very similar. I think I might have a picture of it. Might be the second picture.
This one?
Yeah. So this is a picture of a colonoscopy. It is so what's being inserted here is called a colonoscope. And it's a very thin, about the size of like a writing pen, the width of a writing pen. It's a tube. It's super flexible. It's really cool because it has a light on the end of it and a video camera that projects images onto a screen for the physician while he's, you know, winding through your colon there. The colonoscopy is done under sedation, so you're going to be asleep because, you know, we want you to be comfortable. While they're in there, they're looking for polyps to remove, and they're also looking for other things like, you know, just pouches and whatever they see that might look like it needs attention. Also, for colonoscopies, there's a little more prep involved. So you're going to have to follow a diet the day before, and you're going to have to drink a liquid laxative. And something that patients a barrier for many patients is that usually they have to take a day off of work, either the day prior, just because you're taking the liquid laxative all day and you're going to need to be near a restroom, and it's just more comfortable to be at home for that. And also you're not really eating a lot. You're having like clear liquids, clear jello. I think you can also have coffee, but that would be my saving grace. But yeah, so I think that, you know, this one is definitely the best, or a lot of physicians say it's the gold standard, just because it's, you know, it takes a look through all 5 feet of your colon.
Right.
But there is a lot of preparation for the patient. And even the day of, you're not allowed to have anything to eat or drink, which is why I try to get my patients scheduled like in the morning so they're not crabby that day and hungry.
Right.
Yeah.
So at what age would you recommend people, so like, what are the screening recommendations, like the age that they should start the screening, how often they should start doing colonoscopy, or really any of the other ones, and we have a couple more we'll cover as well.
Yeah, we do.
Yeah.
So screening should typically start for someone who's at average risk at 50 years old.
Got it.
If you have family history or
Any of the other risk factors
Yeah,
that
any
might
well,
make you higher risk?
some of the risk factors, not like, you know, if you have a poor diet or anything like that, or not even if you're, sometimes if you're African American, some guidelines say 45,
Right.
but that's not something that we adhere to really here yet,
Okay.
just for insurance purposes.
Got it.
But yeah, it's 50, and if you have like a family member who was diagnosed,
Right.
a first relative, like a first degree relative that was diagnosed before the age of 50, then they ask that you be screened 10 years prior to that age that they were diagnosed, or 40 years old, whichever is soonest.
Got it.
Yeah.
Got it. So, as an example, if, for say, my father or brother was diagnosed at the age of 45, I would start doing any of these screenings starting at 35.
Yeah, that's
or
one
if
of the
they
guidelines.
were, you know, diagnosed at another time, just 40 and up.
Right.
Right. Okay. Interesting. So, do we have one more type of screening?
Yeah,
too?
so we have a few more.
Okay.
The sigmoidoscopy is very similar to the colonoscopy,
Okay.
except it, well, yeah, it's similar, except it only takes a look at like less than half the colon. So the
Got it.
sigmoidoscope only extends about 2 feet
Got it.
in, but it's a really good indicator of, you know, what your colon is going to look like. If it's clear up through that 2 feet, then you're probably clear the rest of the way, except this screening has to be repeated, if normal, every 5 years. So,
Great.
oh,
Looks like we have a caller. Hello, caller?
Yeah. It's similar except it only takes a look at less.
Sorry, caller, we're having a little trouble hearing you. Can you hear us? Hello? I'm sorry, we can't hear you, caller. Maybe try calling back again? Yeah, looks like we had a little issue hearing that caller. But please, again, if you have any questions, call 312-738-1060.
Hi, yes.
Oh, hello? Caller, can you hear us?
Yes, thank you so much.
okay.
You all are providing some really helpful information. You mentioned earlier about family history,
Yeah.
and I know you all had a show recently talking about genetic counselors.
Yeah.
Is there a way you can, how do you find out your family history other than just knowing that I had a parent or other family member that had colon cancer? Is there something else I can do, like you talked about with the breast cancer, about speaking to a genetic counselor about colon cancer screening?
definitely. We navigate patients to genetic counselors all the time if that's something that they have a concern for. If it is a genetic factor, that's something that can be investigated. If it's not, then, you know, the genetic counselor can work with the patient to, you know, get family members on board to investigate exactly what, I mean, I run into it a lot with my patients where it's like, you know, I remember my grandmother had cancer and it was somewhere in her gut, but I'm not quite sure. And that's where family, like genetic counselors really come into play.
Right, and we did have an episode where we talked to a genetic counselor, and they said that, you know, the best thing to do when you're curious about your family history is that you can always talk to first your physician, who will probably navigate you to a genetic counselor, or you can even get genetic testing for, which I'm not sure if it pertains specifically to colorectal cancer, but I know with family history, probably the best person to start with is your physician, and they can navigate you to other resources like genetic counseling, and then they can help you work through, you know, what your family history might be, you know, other than just asking, you know, your family members and knowing that history. It's a great resource to use. And if you have any questions about that, you can check out our episode about genetic counseling on YouTube at the KNTV website or the KNTV YouTube page.
Thank you. That was helpful.
Thank you for calling. So I think we had one more, just to go back to it, one more style of screening that it seems like, at least for our programs, is used the most.
The next would be like a variety of stool tests. Originally, FOBT tests, which are fecal occult blood tests, were done. And that consisted of kind of the patient got to play like scientist at home. Like you take a kit home from the clinic, you collect for the FOBT 3 consecutive stool samples. And then from those samples, you take like whatever tool that you have in your kit, like a plastic or a wooden applicator, and you take a small sample of that stool, and you put that sample into a little square that they provide, labeled 1, 2, or 3, and you wrap it up and you drop it off at the clinic, and then the whichever clinician will test for blood in the stool, essentially. So that's the FOBT, and that's done yearly if everything's normal. If it's not normal, then you're probably going to be referred to get a colonoscopy just to check it out, because there can be blood in the stool for many reasons, like internal hemorrhoids or whatever, but you just want to make sure that they're not precancerous polyps. And then the FIT test is pretty much the same, except yeah, there's a picture here. The FIT test is pretty much the same. You just have to collect 2 consecutive samples instead of the 3. And it's a little more precise because it's looking for, it's testing and kind of having a chemical reaction with a protein inside the blood, like hemoglobin. So it gets more specific. And also you don't have to stick to a diet like you do for the FOBT of no red meats. Yep.
Great. And it sounds like the program that you're working on right now is through the CDC, the Center for Disease Control. And through that program, what screening are we navigating to?
Okay, so that program focuses mostly on colorectal cancer.
Got it.
Yep, and right now we're implementing interventions within the Cicero Clinic.
Got it.
Hopefully expanding to IHCs, which are nurse run, which would be really cool.
The integrated health centers.
Integrated
We have a
health
couple
center.
Different locations around.
Yeah.
And are we navigating specifically to like the FIT, to the colonoscopy?
So we're navigating to whichever the patient is most comfortable with.
Got it.
We want to give them all the education possible so that they can make a decision with their provider. Now, colonoscopies are pricey, so usually it's best if the patient is covered under insurance, but we do have a grant, not under the CDC, but with another grant to cover a few colonoscopies for patients. And the FIT is covered. We have a grant to kind of give those out for free.
Awesome. And these are all happening at Miles Square Health Center.
These are all
and
at
the
Miles
IHC
Square.
clinics.
Yeah.
Fantastic. And so with the CDC program and the other program you were mentioning, the ACS, American Cancer Society program, MyCare, what was the rationale behind that? We have a few more minutes to go into that.
Sure. Yeah, the rationale is simply increasing screening, compliance. Less than half of the people eligible for colorectal cancer screening get screened. And about 1 out of 5 people will be, faced with colorectal cancer within their lifetime. So just increasing the screening will decrease mortality and incidence.
Got it. And in our community specifically, I know we have fairly high incidence of colorectal cancer and mortality rates of colorectal cancer, sort of around our, like you said some specifically African American communities, and see higher rates of colorectal cancer, which we've seen through some of our data. And just to go into it really quick, you will be at a few upcoming events talking about more about colorectal cancer at Alderman Walter Burnett's Ward Block Party. And this Saturday from 10 to 2, I think, or 10 to 12.
10 to 12,
and then the African Festival for the Arts, which is over Labor Day weekend, all 4 days, Friday, Saturday, Sunday, and Monday. What will you be doing at these events? Navigating or just standing out education?
At Alderman Burnett's event, I think we're just going to be passing out information and talking to people about screening, not just for colorectal cancer, but men's health specifically.
Fantastic.
I'll be there with another navigator who is really, well informed with men's health and prostate cancer. And at the African Fest, this is going to be cool. We actually ordered this huge inflatable colon. It's like 20 feet long, 10 feet high, and it's a depiction of anything that can go wrong in the colon. So you can walk through it and touch it and see it, and it'll really help.
And really quick before, it seems like we had one more caller before we finish. We have about 45 seconds left. Hello, caller, can you hear us?
Hello, yes. Years ago when I was a young man, I was told that colonoscopy was terrible. But I went one time because I wasn't feeling right, and it saved my life. that I did have cancer of the colon. Thank God that was about 10 years ago, and I'm still cancer-free. So for little discomfort, it'll save your life.
I think we're having
Go
a
ahead
little
and get
trouble
that
understanding you, caller.
Thank you.
It sounds like you were asking. Okay, so yeah, sorry, caller. We had a little trouble understanding you, but we're at the close of our show. If you have any other questions, you can go to the UI Cancer Center website or call our hotline or our phone number, which I do not have open right now.
No.
But you can please check out other episodes and channels. And sorry, this is the end of our show. Thank you very much. Have a good afternoon.